This is the talk on the high tibial osteotomy. There we go. And so that patient up there in the upper left, you've seen that slide, that was the first patient that I saw many years ago when it was sent to us from Greece. And that patient was a Greek sea captain. And he had had 2 prior surgeries. You can see it, posterolateral surgery, and it had failed. And we looked at that and we said, we need to correct limb alignment. And at that point, soft tissue operative procedures were being done without the correction of limb alignment. And as Dr. Voida said, they just simply failed. So we started a whole group to look at it biomechanically. We looked at it from a gait, and we started prospective clinical studies to look at it from osteotomy standpoint. That patient in the lower left is Piper, and she's from Kansas. And I'll never forget her because she came in and you can see she has a varus alignment and it's very bad. And she had had 2 prior operative procedures. And when I said to the mother, we have to do what is called an osteotomy, they just, I hate to use the word, they just lost it. They said, you're going to do a 3rd operation on my 16-year-old, 17-year-old child and all the operations before, and then you're going to have to repeat all of the soft tissue procedures. And I was now the bearer of bad news and kind of the enemy of her daughter. And we just had to work and get through all of the psychological aspects for them, because now we're repeating everything and we're doing it. And the only reason I tell you that story is you don't want to miss this. And so just be very careful, as you've heard from Dr. Voidis' talk in this, you don't want to miss these types of varus alignment or valgus alignment and the gait abnormalities. So always check this and look at these thrusts and have them walk. And if you have a limb alignment problem, you have to correct it. Now today we're using osteotomy in 3 conditions. We're using it in younger patients instead of a uni. I'll mention that have medial arthrosis. We're using it before what I've just mentioned, correction of the soft tissue, our lateral, posterolateral, you've heard that. And then prior to cartilage restoration, like Dr. Chieli has said, he has to make sure that he has an alignment correction before he does these operative procedures. So this is a varus malalignment. You can see that. You may not see it initially. Have them walk and see it. And then you can see your valgus malalignment. And this young lady on the right has a valgus malalignment. You can see on the left extremity. And so when she's walked, she's going to collapse into a valgus. And so watch it. And it is surprising today in orthopedic offices how often this gait analysis is not performed. Now, we have to be very careful about osteotomy, because if you go to the literature, you can see that there is an under and over correction problem. That's the main problem. We now have good plates and good locking plates rather than the poodoo plate that's shown there. So we now have really good fixation devices, but we have to worry about the correction and overcorrection. So we have to be very careful in our selection, our initial evaluation, our fixation, our bone grafting, and then our post-operative treatment. So we're doing still a fairly considerable operation, and almost all the problems are technical and under control of the surgeon. So HTO takes time, and it is a difficult operation. Now, you've heard the word that we coined a long time ago, primary, double, and triple varus knee. And the first illustration is primary varus, and that's a varus alignment of the knee. And about 30% of the population has a varus alignment. That's the way you were born. So if we draw a line from the center of the femoral head to the center of the ankle, it will cross into the medial compartment. So that's the weight-bearing line. And we can make a lot of other measurements, but that's a very simple measurement, and it crosses in the medial compartment. It should cross about 50% in the center of the knee. Now, the double varus is when we have a lateral ligament injury, and so the lateral joint gaps open. And when that gaps open, then we have an increase in our varus, and that's the varus thrust that you've heard about. We have the triple varus, and we coined that because you now involve, besides the lateral collateral ligament, you involve the entire posterolateral complex, the popliteus, the posterolateral capsule, and you go into that knee hyperextension, that varus recurvatum that we demonstrated yesterday in our young patient that had a varus recurvatum. And so that's the triple varus knee, and that's just to alert the surgeon as to the different things that must be, different ligament structures that must be corrected after you do the alignment. So all of those are important to make that diagnosis. Now, look at the gait in this patient because it's very interesting. She's doing the varus recurvatum, standing varus recurvatum test. Looks pretty normal. Okay, so we don't have a problem. And so why is she having medial pain? And look what she's doing. She's totally, complete loss of quadriceps control. And she has, in fact, a knee hyperextension abnormality. Look at that. It's going into a dynamic varus recurvatum. That's a triple varus knee pattern. And that gait has to be corrected before we do surgery. The first step she's going to take, she's going to stretch out our posterolateral tissues. So that's a separation. We've measured that with the gait analysis. We were fortunate to work with Tom Andriadaki in our gait lab, who was from Rush and later at Stanford, and taught me a great deal about gait analysis. And this is a very interesting paper where we took 41 osteotomies before and after a high tibial osteotomy. And we, in fact, corrected that very severe adduction moment. And so it shows you that the operative procedure can be successful to correct that large adduction moment that was present. So you have to carefully select the patient. If you have bone exposed greater than 25 millimeters, then that patient is not a good candidate for an osteotomy. Lateral meniscectomy, you're switching your loads to the lateral compartment. So lateral meniscectomy, you may get a short-term benefit, but not a long-term benefit. Lack of extension, some lateral subluxation as the tibia shifts back, teeter-totter knee, meaning that you've got a lot of damage medially, patellofemoral joint. The biggest problem I see is with these big linemen, these big NFL or college players. They wear out their knee, they come in, they weigh 250, 275 pounds. And Coventry, who was the father of osteotomy from the Mayo Clinic and introduced it, later came out with a paper with all of his patients and said that if you're over 200 pounds, you're probably not going to unload the joint sufficiently to get a good clinical result. And so that's the hardest thing that you have to say to big people and big linemen and big muscular people. Look, you lose the weight and I've got a procedure for you, but it's probably not going to work. You're probably not going to be happy with it if we can't get some control of that weight issue. And then unrealistic patient expectation, the patient will want to go back to sports. Here's a 45-year-old patient. You can see on the, always get the Rosenberg 45-degree view, PA view. Don't base it on full extension. You need to flex the knee and see what the remaining joint space is. And so that's not one that we want to do an osteotomy on. And so that's a patient that has a uni. And since the unicompartmental replacements are getting so good, to use that word good, better word to say good follow-up, producing good results in patients, and they like the procedure, many of these patients now are coming to a partial replacement rather than an osteotomy. So an osteotomy is done more and more frequently in a younger population that we can't do a partial unicompartmental on. The published results of HTO then, undercorrection, overcorrection, and up to 40% of the knees, and that's up to the surgeon. And don't overcorrect. You end up with excessive valgus. So you have to be very careful in your measurements at surgery. We go through the measurements of the weight-bearing line. We have that in our textbook, and I won't go through all of these measurements, but you have to achieve a correction and move that weight-bearing line greater than 50%. And we don't want to go greater than 62%. This is a patient, and look at this gait, and what's going on with that? Look at that valgus. That's after an osteotomy of overcorrection. And she was not happy with that at all. And so I had to do a revision osteotomy on her. And that's a big procedure to do. So you have to be very careful with the measurement. We published this book on the 3-triangle method to correct the tibial slope. And so there's different geometry factors the surgeon has to come into play. So we put a guide pin in the tibia, 25 millimeters, distal to the lateral tibia plateau. We want to avoid a fracture. We try to preserve the lateral cortex buttress, but we do drill through it so it doesn't produce a fracture. We do an MCL repair, and then intraoperative correction is the main issue that you have to do with the locking plate. Now, this is a study that we did over 5 years, And it actually took us a fair amount of time to do this. We took the full standing radiographs, and then we took fluoroscopy, where I measured the weight-bearing line, as I'm shown here, and then we used navigation. And the navigation is a great tool to use on very difficult osteotomies, computerized navigation. It takes added time, though. It adds added time to the procedure. And we found that if you really use fluoroscopy at the time of surgery, you can reestablish that weight-bearing line. And I'm pushing at the heel, and the knee is at 5 degrees, and I'm trying to push as hard as I can at the heel to close both compartments. And if I do that, I can get a measurement that is just as accurate as navigation. At least statistically, we showed that. So we were able to drop off the navigation and be able to use this fluoroscopy. So always do this, and I'll do it 3 or 4 times. And then I take my standing radiograph, and don't count on your standing radiograph because it may be inaccurate. It may not just be exactly right. So we get a standing radiograph before surgery, and that gives us an approximation, but we must determine that at surgery. So this is what an osteotomy looks like. You can see that we're making a reasonably smaller incision. We don't have to make a big, large incision. We're turning down the medial collateral ligament. We're going directly behind it, subperiosteally, which is important. We're doing the osteotomy about 35 millimeters from the joint surface. We're putting in 2 pins. We're going to bring in the osteotome along that pin. We're going to follow it with arthroscopy. We're going to dilate the osteotomy site, as you can see here, very gradually. That pin in the upper right, we're penetrating the posterolateral cortex so that we don't have a fracture. Very important technique. I'm putting a staple in the front because I don't want to increase the tibial slope. We use a locking plate. We use freeze-dried allografts, and then we repair the MCL with sutures, and we can use the plate as a guide for that. Postoperative rehabilitation, Tim is going to talk to you about. And just look at that radiograph on the right. We were able to do a biplanar osteotomy and correct that really abnormal tibial slope. So in cases of an abnormal tibial slope, if you close down the joint, you can correct that. And you have to do toe-touch weight bearing and watch out for any collapse because remember, you've got a big gap there that has to fill in with bone. So real fast in terms of closing, this is 41 patients that we reported on osteotomy. 88% would have the HTO again. 78% were able to do light sports, but you know, not any heavy sports. They've got arthritis. So you're just unloading an arthritic portion of your joints. So don't have unrealistic expectations. These are 18 studies in the literature on the closing wedge osteotomy. You can achieve reasonable results. These are 9 studies in the literature on the opening wedge results. So you can have a reasonably good result in a young person, and then you come in with a unicompartmental. So take-home points, don't do it with advanced arthrosis. We talk about observation of the gait, the correction, tibial slope. There's a lot of important things for the surgeon to know. Full standing radiographs, weight-bearing line may be inaccurate. And so you do that correction at the time of surgery, and then a locking plate and screws allows early weight bearing, but even with the allograft, but Tim will protect these. We won't allow full weight bearing until we really have radiographic evidence of healing. So thank you very much for your attention.